Guys, thanks for coming on such a nice day. I toyed with the idea of just trying to have it outside, but that seems impossible, right? Yeah, maybe we'll do a practical portion and drive over to Oxley and like grab some legs or something. Yeah. So I'm Lindsay Goodale, and this is Dr. Radcliffe. He's our speaker tonight. He was my instructor when I was in vet school here. He was definitely one of my favorite instructors. So you guys are in for a treat. He has a really cool couple of specialties, actually. He's a little overqualified for most of what he does. But so he's double boarded. He's both a large animal surgeon, so he does surgery at the vet school on horses and other large animals. And then he's also double boarded in emergency and critical care. So that's kind of his expertise. Why we've asked him here today, obviously. And those are his two main kind of interest areas. He has a lot of sub-interest areas, so colic in particular he works a lot on, of course, orthopedic issues, emergency orthopedic stuff. So anything you've thought of that might be first aid or emergency related courses, he can probably answer your question, and he's probably seen it more than you want to. Yes. And if anyone, little side note, if anyone's interested in falconry, he's an expert in that as well. So stick around and ask questions about that if you'd like. And if you're online and you're having trouble hearing me, don't worry, the mic's on him. And so the audio will get better soon, but do let us know. And of course, he's a nice guy, so I'm sure he'd be happy to answer questions throughout the talk. And thank you very much, Dr. Radcliffe. I just wanted to start this.
Thanks, Lindsay. Welcome, guys. My pleasure to represent Cornell and speak here tonight. I do have a lot of experience, but please ask any questions that you guys have. I wanted to talk a little bit tonight about some of the problems that we see with horses, and I'm sure that you guys know that horses often get into trouble, and they get into everything, pretty much. I mean, if you can think it or dream it, it probably has happened. We have all different types of emergencies that present to our hospital. And not only just horses and other large animals, but horses tend to get themselves in trouble probably a little bit more frequently. They're pretty curious. They're also very large and they're very heavy. And so when they run into things, or if they get kicked or if they get something caught, there's often a fair amount of damage. So I'm gonna there's so many different things we could talk about, but the two biggest things that we see in horses are wounds from different types of lacerations and things like that, and then fractures. Those are probably the most common like equine first aid things that you guys are gonna be faced with. Certainly there's a lot of other problems like colic and respiratory disease and lameness and things like that, but we're not gonna go through everything. So I'm just gonna talk about these two areas tonight. So what is a wound and what is wound healing? So I think it's important to know that it's a process where the skin repairs itself, but the reason for this is really to restore the structure and the function of the tissue. So that's the underlying thought process when we're trying to help an animal with a wound. Now, they're not all this severe. Well, this is what we would call a degloving injury. But we do see these types of things. Again, this horse caught its leg in like a tin shed, and then just with pulling and whatnot, ripped all the tissues off, and you can see the bone here. And even though that looks really bad, we have some really good treatments and methods that can help this recover, and a lot of these horses will do well. So I want to go over some of the most important things that I think about when I see a horse with a wound. Now, there are other considerations, but probably the most important things are the type of the wound. We'll talk more about each one of these areas. The degree of contamination, which really is the degree of foreign material and bacteria and things like that that are present in the wound. The location of the wound does make a large factor in what decisions we make, and I'll talk a little bit more about what I mean by that. Tension is an area of concern because if there's a lot of tension in an area where the skin has been damaged, it's difficult sometimes to close, and sometimes it doesn't heal properly. So we have to deal with tension. We'll talk a little bit more about that. And then the nature of the wound, I'll just mention some other factors that we look at. So back to the type of wound. So because there's so many different ways that horses can become injured, there's lots of different types of wounds that we see. So probably one of the most common is just a laceration, we call it, which is usually a sharp transection or a sharp wound that's created by a relatively sharp object, like a fence or maybe a sharp piece of equipment in the barn or something like that. Abrasions are more of where they've scraped or fallen down and slid on something, and they've lost the superficial epidermis and some of the dermis, so losing parts of the skin. Contusions is really just a forced traumatic injury where there's a lot of bruising and injury to the tissue, but not a big laceration, just trauma, and you get a lot of injury to the tissue, but it's blunt trauma. And avulsions are where you have kind of like torn off tissue, like that first horse with the degloving injury where he lost all of that tissue on his leg. So those are some of the more common things that we see. This would be considered not only a laceration because you can see it's cut here, but also it was a contusion. There's a lot of swelling and drainage and also infection present in that case. So next we think about how contaminated the wound is. And it's partly how much dirt and debris and foreign material, but equally important is the amount of bacteria or other infectious organisms that may be present. So we have a degree of contamination that goes from clean to infected, from least contaminated to most contaminated. And these are more like terms that we use as veterinarians. But as you can see, some of the more clean wounds are things that are like a surgical wound, something that we prepared and it doesn't have contamination. Down to where we have an old traumatic wound that's infected and draining and so forth. And there's a whole variety in between. So this would be considered a clean contaminated wound probably. It's a sharp laceration, but there's probably some degree of contamination. This is when we would consider it infected because we already have active drainage and it's older and a lot of swelling and whatnot. So anyway, the degree of contamination will affect not only the prognosis, but also what we decide to do with it as veterinarians. Location, I mentioned earlier that location is important when we're deciding how to evaluate and treat a wound. So the things we think about are all of these factors here. And as you move more distal on the limb, these things become more and more problematic. So let's go through the decreased blood supply. So there's decreased blood flow to the distal limb because we just have fewer vessels and less blood pressure as you get more distally. There's more of these bony prominences or just bony projections like the point of the hock or over top of the bones of the hock or the fetlock or other bones. And those bony enlargements underneath the skin, if there's a wound there, they often have a challenge. They challenge us because there's a lot of tension associated with that, and they're also quite mobile. So we'll get to some of those things. And so if there's a lot of movement around a joint and there's a lot of tension, then that makes for a much more challenging situation. Also, you tend to have a lack of muscles and just mostly tendons in the distal limb. So muscles tend to provide some protection, but they also provide a source of blood to the healing tissue. So without the muscles, you're going to have decreased healing. You just have tendons and ligaments. We talked a little bit about the highly mobile joints of the distal limb. So again, the more movement, the more problems with wound healing. Higher contamination as you move from proximal to distal or towards the ground, as you might expect. There's just more dirt and fecal material and so forth as you get lower down. Contraction is a term that we use to describe the wound contracting down in size, and that's an actual a biological event that happens during wound healing, where the wound will contract down. And if you're in an area on the distal limb, wound contracture doesn't work very well because there's a lot of tension in that area. But it works really well in the upper part of the body, like on the abdomen or the thorax or on the neck and things like that, because you have a lot more skin that's mobile to move and contract down. So anyway, we don't have much ability to contract on the distal limb. And then also we have this problem called exuberant granulation tissue. And what granulation tissue is it's the body's first response to prevent against infection. And what it basically is doing, and here's a horse that has this, it's this pink tissue. I'm sure if you have horses, you know what this is. It's this granulation tissue or pink tissue that forms in a wound. And it's just this fibroblasts and other tissues that are trying to improve healing. But one of the most important parts of this granulation tissue is it forms a barrier to the underlying tissue, so it can help prevent an infection. Unfortunately, if you don't have wound healing progress normally, you can get a lot of this tissue. And when it becomes excessive, and what I mean by excessive is if the granulation tissue is protruding beyond the level of the skin, we would consider that excessive. And what happens then is you cannot have the epithelium, which is the skin cells surrounding the wound, move over top of the wound. It's like there's a mountain of tissue there and they can't cross the mountain. And so this really impedes healing. And one of the things that we do, and I'll talk about this a little bit later on, is we cut that away so that the mountain of tissue is gone and the epithelial cells can cross. Anyway, so you can see there's a lot of problems with the distal limb wounds in horses. And so that's something to think about when you have a horse and you have a wound. I talked about tension, and so the more tension you have in a wound, the more difficult it is to close, and the more likely it is that it may become a non-healing wound, or that it'll have problems healing in an appropriate amount of time. So some of the problems that create tension, these bony protuberances like the point of the hock or the shoulder, when you're surrounding joints, there's a lot of tension and there's also a lot of movement. As you get lower on the limb, like I said, there's not really any free tissue in the skin to be able to expand during healing. So that's a limit. If you have large amounts of tissue loss, like that first horse on the lower limb, that's going to result in a lot of tension if you tried to close that. And then if there's a lot of swelling, that will also be a problem. If you look at this horse, this is the back of a horse's front leg in the area of the elbow, and there's just a lot of swelling here because of this wound, and because of that swelling, there's actually a fair amount of tension here, even though it's a little bit higher up on the limb. So what we would do first with a wound like this, and there's a fair amount of discharge here too, is we would treat it conservatively, and what I mean by that is clean it out as best as we can, maybe use cold water to flush it, and then once the swelling is down, then we might try and close it in what we call a delayed wound closure. You could also let it heal by what we call second intention healing, which is where you just kind of let it heal with, you can treat the wound, but you're not actually trying to suture it together. So anyway, a lot of different problems that can create tension and make for a more challenging wound. So the last area that I want to mention that affects wound healing is the nature of the wound. And so what I mean by that is there's lots of different factors such as drainage, swelling and infection, if there's a lot of necrotic tissue, if you have a foreign body, a really large wound, or if there's damage to the blood supply. all these things will affect the outcome and may affect what we decide to do. So here's a horse that has this large flap wound over top of the sinuses between the eyes and on the face there, and it looks horrible. But as a veterinarian, I look at that and I go, oh, that's not too bad. And the reason I say that is because the head has excellent blood supply. And one thing that looks concerning here is that you can see that this flap that's fallen down here is all dried out and it looks like it's going to die. And yes, you should be concerned about that. But if you have veterinary attention in a reasonable amount of time, like probably within 24 hours even, this can be cleaned up. We use a lot of saline, lavage. We try and rehydrate the tissues. We debride it to remove any foreign material, and then we close this. We often put a drain in, which is placed here to allow for fluid to drain. But this horse healed up, and in fact, there was no loss of this wound during healing, which you might think is amazing. But remember, we have excellent blood supply. You see all the bleeding vessels here. So the skin in this area has a lot of blood supply, even though there's actually not a lot of muscle up here. But the head has a lot of blood supply, so that works in our favor in some cases. So let me talk about some different methods of wound management next, because as a veterinarian, we make a lot of decisions, and I think it's nice as a client or horse owner to try and kind of see that there's different options involved. So anyway, we have one of our principles called the golden period, which is the time that we consider a wound, the period of time where we can close it primarily, which means that we can suture it closed. That we say 4 to 12 hours, but you can actually do this beyond that, and depending on the wound and what it looks like, up to 24 hours probably is a reasonable amount of time. Again, it does depend on the wound, but you can certainly stretch that time period. So it does depend on the type of wound, and so we don't want a lot of contamination, because too much contamination and we close it, it'll just get infected, and there'll be a lot of drainage, and it'll what we call dehiss, which means it'll fall apart, and it won't heal. So if there's a lot of infection or a lot of drainage and contamination, we don't like to close it right away. This is a wound on a horse. This is a horse under anesthesia. He's actually on his back. This is the axillary area right underneath the front leg. On the horse's left front leg, this is the sternum brace, so he's on his back. And the horse tried to jump a fence, and the fence post caught and cut in through that axillary area. Now, yeah, that's a really serious injury, especially if it happened to go into the thorax, which it did in this case. But you notice that this wound is very clean. There's not a lot of foreign material that we can see. This was a metal post, and it was relatively clean, so it was a clean cut. And so that's good in the fact that we potentially would consider closing that. There was a lot of other things we had to look at here because it did go into the thorax. We had to make sure that the lungs and the rest of the thorax was not traumatized. And this actually penetrated through the diaphragm as well, which meant it went into the abdomen, and so we had to make sure that the abdominal cavity was okay and that the intestines were not damaged. But in this case, the horse got really lucky, and we were able to close the hole in the diaphragm, and we were able to close this wound. Partly the reason we were able to close it was because it was so clean. And also, there was not a lot of trauma here. Yes, there was a laceration and a small opening in the muscle here, but it was not a particularly traumatic wound in the fact that not a whole lot of damage to the tissues in that area. Also, there was, this wound is fairly ventral on the horse, so when we close that up, there's going to be good drainage ventrally. If this was on the horse's back or up on the top of its withers, then you'd have much more trouble with drainage, and you'd have to do some other things to make sure you didn't get a lot of fluid accumulation. And if you get a lot of fluid accumulation in the wound, then that will result usually in failure, because it won't allow normal healing. You'll get a lot of drainage and whatnot. And again, we also are looking at what's the condition of the patient. In this case, the horse was fine, and we were able to do this procedure under general anesthesia safely. Here's just an example of a horse we have under general anesthesia. Now, you don't have to close all wounds under general anesthesia. I don't want to give you that impression, but there are wounds where it is important to be able to lay them down on their back and do things that you couldn't do in a standing horse. And I'll show you an example of that. But largely, most of our wound repairs are actually done standing with sedation, local nerve blocks, local anesthesia. Rarely do we have to use general anesthesia like in this case. So here's a horse in the upper right-hand corner that I'm going to show a few pictures of. This horse required general anesthesia. I'm not going to take a lot of time, but let me just tell you the history of this horse is they were trimming the horse, and the farrier had the horse's back leg on the farrier stand. And if you've ever seen that, they come in different types and whatnot. This is a metal tripod stand, and the horse slipped, jumped, and fell down on the farrier stand. And the farrier stood up, and the farrier stand was hanging from its abdomen. They were able to get that out, but it had punctured the abdomen and gone into the gastrointestinal tract here. So I'm going to kind of talk a little bit through that. But that's a serious wound. As a client or as a referring veterinarian, the first thing you should do with that, if there's intestine coming out of it, is you should wrap it with like a bed sheet, just to get it up and protect it next to the abdomen. It's much better to have it against the abdomen than down on the ground, because if they step on it and pull it apart and rip it, I mean, it's pretty much over. If you can protect it, and in fact, if you look closely here, this is a bed sheet that the owners had wrapped around, tied around, so that the intestines were stuck against the abdomen. That's the smart thing to do. We saved this horse because they did that. Had they not done that in the 20 to 30 minute trailer ride it had to get here, its intestines would have been all over, and they would have stepped on it, and we would have had to euthanize the horse. Anyway, back to kind of the wound here. The first thing that we're going to do is what we call wound preparation, which is we're going to clip, and we're going to, we often use some sterile lubricating jelly to protect the wound, but then we clip and we scrub and we rinse with saline. It's important to rinse with saline and not alcohol. Some people think that, well, you scrub with betadine or chlorhexidine, then you rinse with alcohol. When you have a wound, you don't want to rinse with alcohol, because alcohol is cytotoxic, which means that it'll destroy living cells. And it's fine on skin because that's a protective covering, but once you get down into live tissues, then it'll cause damage. And so we rinse with saline, which is just like normal fluids in your body. And then we clean around it really well, and then we lavage, which just means we pour lots of fluids over the wound and clean it up. And in this case, we poured a lot of fluids, as you can see here, over the intestinal tract too, trying to clean that up. But you can see the source is under general anesthesia. We could not have done anything. We couldn't have done anything really valuable to this in a standing horse. As we move on here, the next thing we're going to do is evaluate the wound. So we've cleaned it up. So here, this is that same horse. We've clipped it, we've prepped it, we've got some sterile gloves on, and we've actually evaluated the intestines and then pushed everything back into the abdomen because we need it inside for us to take a better look. It's really difficult to do anything this way. So exploring the wound and then checking for communication and things like that with areas like joints or synovial structures. Sometimes we use ultrasound or radiographs to help us decide what's happening. In this horse, we needed to get the intestines back in the abdomen so we could proceed on to what we call a ventral midline laparotomy, where we open the horse up like a colic surgery to evaluate its intestines. Then next is what we call wound debridement. And so this is still prepping the wound. but we're actually closing this now so that we can go ahead and clip everything and then sterilely prep this in preparation for an exploration of its abdomen. But wound debridement is where we're removing abnormal contamination and dead tissue and making it for a better wound to close. And we did a little bit of that here as well. So I mentioned the different types of wound closure. There's really 3 types. Primary wound healing, which I remember I told you was the golden period. You can go out to 24 hours with that. Second intention wound healing is where you've lost so much tissue that you really can't close anything. Like that horse in the first picture that lost all the tissue off the front or off its hind leg. We would do a second intention healing where you're basically allowing it to heal, but we're just treating it with bandages and debridement and things like that. But we're not closing anything. And then tertiary wound healing is really delayed wound healing. And that's for wounds that are very swollen, infected, a lot of drainage. And those, we like to delay closure for about 3 to 5 days, sometimes longer. And what that allows us to do is it allows us to get the infection under control or the drainage or the swelling so that then we have a much better chance of this wound healing. Because if you just close a wound that's infected or swollen, often you're going to have a dehiscence where the thing falls apart because there's too much drainage and anyway, lots of different complications. So this delayed wound healing can be valuable and probably, I think, underutilized because we're often, we're intent on primary wound healing, but sometimes that's not the best choice. All right, so this actually is that horse that landed on the farrier stand, and this is after surgery. This is the abdominal incision where we explored the abdomen, and this horse was lucky. He had some inflammation of his intestines, but no trauma, like no holes or contamination of the abdomen, which likely would have resulted in euthanasia. So we were able to clean everything up and close our incision. We put an abdominal drain in. That's just because the abdominal cavity was contaminated because of the farrier stand. So we have to clean that out, and so that's a way to do that. And then this is our original wound, and we have a drain underneath there so that the fluid will come out and not accumulate underneath the area of the wound. Anyway, so that's what it looks like after surgery on that horse. So this was that horse at the beginning that I showed you where he lost all this tissue. We really can't close that primarily, and we can't really do a delayed wound closure. So this is by really default, we have second intention, or what we call secondary wound healing. And that's basically allowing the body to help in the healing process. What's going to happen first is you're going to get there's a lot of inflammation, and then the granulation tissue is going to come in. And then once that granulation tissue covers all of this wound, then you'll start to have wound contraction and the epithelial cells crossing. But this is a long haul for this horse. And this horse did heal, but it was months, probably about 6 months before this was healed. So this delayed wound healing, also known as tertiary wound healing, it's for these severely contaminated or swollen wounds where we don't really want to close it right away. And so here's a wound kind of in the lower aspect of the pastern here above the hoof capsule. It was really swollen, a lot of drainage. And then also synovial means like a joint or a tendon sheath. And those structures, if they're involved in a wound, can be terrible, very terrible news for the horse, because if it gets infected, that's very difficult because the horses get very lame and it's hard to get the infection removed from those areas. But if we do have a wound that's been compromised and like a joint, like in this case, the coffin joint was involved, we were able to flush it out and treat it aggressively, and the infection did not result, so the horse did well. But if the infection develops, they get really lame, like non-weight bearing lame. And so they can't really survive that very long. And it's difficult for us to remove the infection once it's set into those tissues. Anyway, so this wound, we closed after about 5 days. And the swelling was down, there was no drainage, and it went on and did fine. We do a lot of other things in wounds, and I'm going to go over some of this just so you can see other things that we do. When we have a lot of tension, we often put in tension sutures, which actually I don't show here, but this was a horse that had a laceration into its thorax, and on closure, we did use some skin suture, tension sutures, which can help close a wound that's under a lot of tension. We also put in a bunch of what we call relief incisions, which are all these little, it may be hard to see here, but lots of little incisions here that allowed us to close the main incision, which was right here. And this is where the horse had the trauma. And then a lot of times we're using drains, like I showed you in that other case, but here's another type of drain, which is like a tube that we can suck fluid out of. A couple of the other techniques we have. We use a lot of dressings, which are basically whatever you're going to put over top of the wound. And we have lots of different types of dressings. And I guess just to summarize, there's dressings that do just about everything. And so we as veterinarians look at the wound, and at different stages of wound healing, we choose different dressings depending on what we want to have happen. So when we first have a wound that's contaminated, we'll often do what's called a wet to dry bandage, where we put on wet gauze and then we take the bandage off in 24 hours and the gauze has dried out. But when you take that off, it basically peels away all the contaminated tissue. So we do that really early in a wound. And then we use some of these non-adherent dressings. You may have heard of these, like Telfa pads. Those are excellent for when you're having the epithelial cells crossing the granulation tissue bed, because when you change a bandage, the Telfa pad or non-adherent dressing won't pull off the epithelial cells. Anyway, so lots of different things to learn about there. Bandaging, we do a lot of bandaging in wounds. They have a lot of different functions: protecting the wound, absorbing exudate and blood, removing tissue and bacteria, preventing contamination, decreasing swelling, minimizing movement, and on and on and on. So they're really important, and there's lots of different types of bandages and splints and whatnot, even casts that can be applied. And that's a judgment based on the type of wound and kind of those factors we already talked about. We also have, for infections or areas where we're concerned that infection might develop, we have a lot of techniques like local antibiotic delivery. Here we're delivering antibiotics below a tourniquet and perfusing the tissues in high levels of antibiotics, which can help prevent an infection or treat an established infection. We also have antibiotic impregnated beads that we can put inside tissues. Here's a foal that had a septic physis and a septic elbow joint. This is just part of the bone, and this little oblong piece that's kind of whitish here that looks maybe like a worm is actually a bead of antibiotics that we put into that infection. And that's going to release antibiotics for a long period of time. We also have some other special techniques that we sometimes use depending on the wound. We have skin flaps, which are where we move tissue around in certain wounds because we need extra tissue, typically done on the upper part of the body because we don't have room or there's too much tension on the lower leg. And then skin grafting, which is shown here, where we collect some little tiny pieces of skin, often under the mane or on the abdomen, and we put them into our wound bed, and it helps speed healing because now you have all these little islands of epithelial cells that are going to help improve the healing. So that's called skin grafting. Many different techniques, but that's one type there. Vacuum-assisted wound closure is a technique where we put a vacuum or negative pressure on a wound. It helps really serious wounds where we're trying to remove bacteria and necrotic tissue and also promote healthy granulation tissue. And this actually was done on that horse with all that tissue loss on its lower leg. and it helped result in an excellent granulation tissue bed, and I believe helped healing in the long run. There's a lot of complications. Proud flesh is one of those things I talked about. Here you can see that it's all necrotic here, but it's extending beyond the level of the skin. And so what we did is we cut that off. And yes, there's some blood loss, but not significant. And we basically remove that and then bandage it again, and the epithelial cells will cross over much quicker. In this case, that'll really never heal unless it's treated by removing that tissue. You might also have bone injury or tendon injury underneath the wounds. Here's a foal that had a wound, and then it had actually a fracture of its femur. You got to make sure there's not something like that going on. Here's a horse that had a severe laceration over its fetlock that lacerated its superficial digital flexor tendon and part of the suspensory ligament. So that needed to be in a special splint for healing. We talked about synovial involvement, which is wounds that go into joints or tendon sheaths. You also may have trauma to the thorax or the abdomen. And that could be challenging, like the one that I mentioned, because it can be life-threatening. Here, a horse ran into a fence post, and this was stuck in there. Luckily, this went alongside the rib cage in this horse, and he did fine. This horse was not so lucky. He landed on a fence post that went into his thorax, and although we stabilized him, his prognosis was extremely poor, and he was euthanized. When you do have an injury into the thorax, one thing that you can do is wrap, this is just saran wrap over top of a bandage. And what the saran wrap does is it seals the abdomen, or seals the thorax, so that, because one of the problems here is if it goes into the thorax, the air will be sucked into the thorax during respiration. And you want to prevent that. And the way to do that is to wrap it in saran wrap, and then you can put a bandage over top of that, but that'll prevent air from going in and out of the thoracic wound, which will help stabilize the horse and might save its life. And then, of course, there are burn injuries, often from barn fires, that can be severe, and there's different types of degrees of burns and different techniques that we use for these as well. So I did mention that I was going to try and give you some advice on how to be prepared. Well, first I would say have a plan in place, which means think about what can happen and what you would do if you had an injury to one of your horses or other animals. And that could mean, you know, thinking about, well, do I have a veterinarian that I can call? Or do I have a friend that can help me? Or do I have the right equipment? Do I have bandage materials and antibiotics and things like that? So you should also have a list of numbers, your veterinarian, maybe your farrier, friends that can help you, somebody that can trailer if you can't. These are all things that you should think of ahead of time, because when it happens, you know, time sometimes is of the essence. And then some basic bandage materials would include like roll cotton, brown gauze, vet wrap. These things your veterinarian can help you stock at your farm, so you could put on a bandage to help stop bleeding or until the veterinarian got there for further evaluation. And having some medications like antibiotics or anti-inflammatory drugs would also be appropriate. But as a basic, I think those things you should think about and have ready if you own horses or other large animals. All right, for the last 20 minutes or so, I want to talk a little bit about fractures, because these are another problem that we see in horses, and it can be very severe and life-threatening. Lots of different types. We often describe them as displaced or non-displaced, simple or comminuted, closed, open, stable, unstable. Basically, that's describing the severity of the fracture. Displaced just means that the bones are separated. Whereas non-displaced, there's a fracture, but the bones are still intact. Comminuted means there's all kinds of pieces. Simple just means there's one fracture. Closed is that there's no wound to the outside skin. Open is when they're open to the outside. And why that's important is because if you have an open fracture, a lot of times what we tell clients is depending on the situation and the bone involved and whatnot, if it's open, that will raise the cost of our care just about double and decrease the prognosis at least double. And when you're talking about a fracture, it's probably even more than that. Because if you have an open fracture, a lot of times what will happen is our implants, which are like our techniques to repair the fracture, are at the very limit of what we can support with this massive animal. And if it gets infected, then those loosen up. And so we no longer have stability. And one thing that, if you remember anything about fractures, is they will not heal unless they're stable. So an unstable fracture, forget it. It's not going to heal. You must have stability for the wound, or for the bone to unite. Anyway, so lots of different things that we think about when you talk about a fracture. So what do you do when you find out you have a horse that might have a fracture? Well, first of all, the most important thing is try and see if you can identify, is this truly a fracture? Should I be concerned? And then immediate mobilization and try and prevent it from being open if possible. And the reason to immobilize it is exactly that. Try and keep it to be maintained as a closed fracture if possible. And I would say a large percentage of the fractures are closed at the time of fracture, but become open either during transportation or movement of the horse when the limb is not appropriately stabilized, which means you want to help make sure that the limb is really rigid during transportation and management so that you don't have problems develop. We'll talk more about that. We often instruct the owner not to move the horse. You can administer some non-steroidal anti-inflammatories, or if you have some sedation, is appropriate if you have things that you can give at the farm. A lot of that may require your veterinarian. If the wound is open, you can clean it. Also, if there's any bleeding, you'd want to apply pressure. But generally, you're going to want to keep the horse calm and immobile until the veterinarian arrives so that it can be stabilized appropriately. And I'm going to kind of go through some different techniques for stabilization just so you have an idea of what can be done. But realize that you probably can't do this yourself, that you need somebody highly skilled that has had a lot of training in how to make sure this limb is appropriately stabilized prior to shipping. Not that I wouldn't try, but just that it is not easy sometimes to get this done properly. When the veterinarian comes, we're going to look at the horse's temperament and make sure if it's really painful, that we're going to give it analgesic or pain meds, and also sedation if the horse is really anxious. We're going to check its systemic health to make sure it hasn't had a lot of blood loss, and if so, we may have to give it fluids or blood transfusions or other things. And then once we've done that, then we're going to, the most important thing about the fracture is stabilization of the limb. So here's a horse that has a radial fracture, and note here, it's already open. And so that's a really bad sign in an adult horse. And certain fractures are worse than others, so location and type of fracture is important, but your veterinarian can help you decide that. Some horses, euthanasia is really the only option, and in fact, if you're talking about a distal radial fracture that's open in an adult horse, the prognosis is extremely grave, and euthanasia is almost always either performed or eventually happens, regardless of what. We just can't, we don't have the ability to save those horses. So as a veterinarian, we're also going to look closely at the location, the stability, all those things we talked about to help give you an idea of prognosis, cost, and a plan for moving forward. Radiographs are really important, and we can do these in the field with these portable X-ray units. We get really good quality images. We can share those with the client. We can share those with our referring veterinarians and the referral specialists if needed. But we're looking for what bone, the type of fracture, if it's stable or not, how much damage to the bone, and also if there's any soft tissue injury. Lots of different types of fractures. This is what we call a slab fracture, which is a vertical fracture of a bone in the carpus, common in a racehorse. This is a fracture in the metacarpus or the cannon bone of a foal. Both of these cases are pretty good candidates for surgery. If this one's open, we're more concerned about it, but if it's in a foal, we're much happier than if it's in an adult horse because of the weight difference. I mean, we have so much better success because we don't have to deal with the stresses of the animal immediately needing to be weight bearing following surgery. Or even if they are, there's not a whole lot of forces from the weight of the animal. So fracture stabilization, what do you need to know? So basically, it's the most important thing that can be done in the field. And that's because we want to stabilize the fracture to prevent damage to the fracture and the soft tissues around the fracture, which also means the blood supply to the fracture and any nerve supply in that area. It's probably the most important thing that affects prognosis after the type of injury is how you stabilize the fracture in the field. So why would you want to stabilize the limb? We want to be able to assist weight bearing, avoid greater damage to the fracture. We don't want an open fracture. Remember, that carries a relatively poor prognosis in a lot of fractures. We want to protect the blood and nerve supply, and we want to prevent further damage to the bone. So lots of reasons to stabilize a fracture. And here's a horse with a tibial fracture that has a lateral splint up the leg. Generally, what we're going to do when we stabilize the fracture is we're going to put on a bandage, and then we're going to put some type of splint on to help stabilize that the damaged bone. You have to know your anatomy, and there's lots of different things to consider. But probably the most important rule that I would share with you is you want to follow the rule of cast application. And if you're not a veterinarian, what that rule is you want to stabilize the joint above and below the fracture with your splint. So if you had a horse here, here's a horse with a cannon bone fracture, you're going to want to stabilize the limb from the ground all the way up to the stifle. And that's because in the cannon bone, the joint above it is the hock, so we have to stabilize that joint. And the joint below it is the fetlock, so we have to stabilize that joint. What I mean by stabilize is that joint, you don't want it to move. So you don't want the joint above the fracture or the joint below the fracture to move. That is the best way to preserve the bone and the integrity of the soft tissue surrounding the fracture. So there's some principles here that I share every time I speak about this with my veterinary students and others. One is just what I told you, stabilize the joint above and below the fracture, which means don't let the joint above or below the fracture move. And I'll show you how to do that. You never want to end your splint in the middle of a long bone. So you'd never end any type of fixation, whether it's a splint or a cast or a bone plate or anything in the middle of a bone. You go up to the joint above. And that's because if you end your splint right at the middle of the tibia, then there's a lot of force there and you might actually break the tibia. If you end your cast at the middle of the cannon bone, then you might break the cannon bone. So you should go up to the joint above so that the forces of that fixation are spread around a joint and not around the middle of the bone. You never end a splint near the fracture site. That's just because it's going to cause displacement of the fracture and more problems. And then we always try and put 2 splints at 90 degrees when possible. And that's just because 2 splints at 90 degrees helps prevent against bending in lots of different directions and torsion, which are the 2 of the main forces that we're worried about in creating further trauma to the limb. So I'll quickly go through and just show you a few examples here. So if you have a distal limb fracture, which is mostly like P1 and P2, there's a couple different things you can do. You can use this Kimzey leg saver splint, which is this aluminum splint that you can strap on over top of a bandage. Or you can put on the back limb, you can put a board or a PVC pipe. and bandage the wound to that so they're in vertical, the hoof is in vertical alignment with the cannon bone here. So that's basically what these two techniques do for lower limb fractures. And here it is on the hind limb of a horse. And notice basically what we're doing is having them stand on their toe. The reason for that is we've turned this, all the forces coming down through the hind limb are now in compression, which means just like pushing straight down. Whereas in the normal situation, as soon as you get to the fetlock joint, there's a lot of bending forces here, and bending is worse than compression. So we try and get everything into just vertical compression because that's a little bit better for the fracture. So various different types of lower limb fractures. Here's a P1 fracture that had some screws placed. Here's a P2 fracture. Here's a P3 fracture. So lots of different things that could benefit from some type of fixation. P3 fractures actually, the hoof is relatively stable, and treatment of these often just involves putting on a special shoe. So those don't really have to be stabilized for shipment. Robert Jones bandage is often what we use underneath the splints. It's basically just cotton, which is shown here at the top and the bottom, and then brown gauze, which is this gauze that you can help tighten the bandage up, and then vet wrap, of course, which I'm sure you guys have seen, just to kind of secure it. And then the splints are placed on top of that. Here's another Kimzey Lifesaver splint placed on the front leg. Again, notice how he's walking on his toe. This is a fracture like in the cannon bone in this area. So in this area, and we're putting a lateral and a palmar splint or a plantar splint. So two splints at 90 degrees, one on the side and one on the back. That's going to give the best stabilization of the fracture down here. And remember, we're trying to stabilize in this cannon bone area, the fetlock joint, which is here, and the carpus or the hock, which is up here. So the splints have to go all the way to the joint above those two. If you end at the joint above, then you're not stabilizing that joint. You have to go all the way up to the joint even above that. So you have to think a little bit when you do this. When you're talking about fractures in the radius or the tibia, often what we'll do is we'll put just one lateral splint from the ground all the way up to the shoulder or on the back up to the hip area to stabilize those fractures. And here's another example on the front leg. Olecranon fracture. The olecranon is part of the elbow, and you can see there's a fracture here in the elbow of this horse. Well, they look like this on presentation, or when you see them, they have a dropped elbow and they cannot extend their limb. So it looks like this, and so they're often dragging that limb. And basically what we're going to do here is we're going to put on a caudal splint from the elbow all the way down to the ground. And what that's going to do is extend their leg so they can weight bear on it. And you might think, well, why would you put a splint from the ground up to the elbow when you told me you never end your splint at the fracture site? And we did in this case. We're putting the splint right here, right at the fracture site. Well, let me tell you why. The olecranon is not a weight-bearing bone. So it does not support the weight of the horse. The weight of the horse is supported through the radius. And if the radius is not fractured, which most of the time that is not the problem is the olecranon. The weight bearing is going through the radius. And so the only concern here that we have with this horse is he can't use his leg. So we're going to straighten out the leg and let him use it. And then he'll be much happier and we'll be able to deal with the fracture. And having the splint ending at the fracture has no problems at all because the fracture is stable because the radius is stable. And that's basically what's happening here. We're putting this horse, this splint, so he can walk again on the leg. And that is an exception to those principles I showed you. Tibial fractures, there's the tibia is here. There's a special Thomas Schroeder splint that may be used, more commonly used in cattle than in horses. Once we get above the elbow and the stifle, so on the upper body, generally we don't splint at all because there's really no ability to stabilize those tissues. And they're also already surrounded by a lot of muscle. So even though the prognosis is relatively guarded for those fractures, some of those do go ahead and heal because there's so much muscle surrounding that bone. And if they're a horse that will stand for long periods of time or are very careful on their limb, they may be able to stay in the stall for a period of 4 to 6 months, and they may have healing of this fracture without surgery. Other things that we could do for other challenging fractures is putting them in a sling like this Anderson sling here, and that helps reduce some of the weight that the horse has to place on the fracture. It's challenging. Some horses don't like to be in these. Others tolerate them quite well, so it does depend upon the demeanor of the horse, but it can be helpful. Oh, and don't forget about fractures in the head. Horses are notorious for catching their mouth on part of the stall or on a gate and just pulling back and then ripping some of these teeth out. And we can, various different techniques, but there's a wiring technique where we just basically wire the teeth back together. Very commonly seen and very commonly done. Fractures of the head and the face, those we just try and remove any fragments and then close the wound. Lots of complications with fractures, from laminitis, infection, implant failure, failure of the bone, limb deformities, colic, you name it, it can happen. How do you transport a horse with a fracture? Generally, we like to put them in the trailer with them loosely tied so they have the ability to use their head for balance. But then also there's this saying that I like to tell my students, and that's called crack in the back. And that means put the fractured leg in the back of the trailer. And the reason for that is you have two forces during trailering, and that's braking and acceleration. And the worst of those is braking. First of all, you can't control it, and you may have to brake quickly, but it's the biggest force that's gonna be applied to the horse's legs. And the braking forces are applied to the horse's legs in the front of the trailer much more than the hind or the back part of the trailer. So if they have a hind limb fracture, you want to load them facing forward. So the normal front limbs are going to take the braking forces, and the broken leg and the rear end is going to be in the back of the trailer. And if it's a forelimb fracture, then you're going to put them in backwards so that the forelimbs are going to be taking, the back limbs are going to be taking the braking forces in front of the trailer. So just remember, crack in the back. And then, how do you be prepared for fractures? It's not much different than for a wound. I think you should have a plan in place. Think about what you would do. Have your list of important contacts and some bandaging supplies, splints, medications. Again, all of these things your veterinarian can help you set up and have available so that you're all set when something like this would happen. Hopefully not, but these horses do uncanny things sometimes. Well, with that, that was my last slide, I think. And if you have any questions, I'm happy to try and answer those. Anything back there? I thought I heard yes.
How long, generally speaking, does it take a broken bone to mend itself?
That's a great question. Yes. So, and you know, that's it's challenging in horses not only because of their weight, but also it does take a long time. And there's a difference between a foal and an adult horse. But generally speaking, you're looking at about 4 months, sometimes 6 months for a fracture to heal. And that's complete healing, and that's in an adult horse. And if you have complications, it can extend beyond that. Like if it gets infected, or if it's not stable. In a foal, you can expect healing in about 2 to 3 months. And again, that depends upon the type of fracture and the age of the foal. But about half the amount of time, maybe not quite, but something about like that. So around 3 months for the foal and 4 to 6 months for the adult horse.
During that time, do they have to be completely confined in a stall, or is there like a way? Like
no, so that's a great question. Typically, what we have as recommendations as the first the most critical time is probably the first couple of months. And so usually they're in a cast for part of that, although we're trying to back off the use of casts. And so there are some other things that are being done, but often they're in a cast for a period of 4 to 8 weeks. And during that time, they often have to be kept in the stall anyway, because we need to be able to monitor them, make sure they're not having problems with their cast. And then after that, after the cast comes off, they're often in a bandage or a splint or maybe a bandage cast or something to try and, we're basically starting with the most stable, and then over time, as the bone is healing, we're taking some of that stability off. So it'll go into a splint, and then it'll go into a bandage, and then the bandage will come off. And that takes a period of months. And during the time where, as you get more and more towards a splint or just a bandage, we do more and more hand walking and start increase the level of activity. But there's really not going back to any type of work at all until we have radiographic evidence and physical evidence of pretty close to complete healing. Yeah, so it's a long time. And a lot of complications that can happen in the meantime. All right, well, hey, oh yes, question.
Do you find that it's almost better to have a fracture on the hind limbs rather than the forelimbs, since they bear less weight on the hind limbs?
Yeah, that's a great question. It does depend on the fracture. But yeah, we do sometimes are happy when they are on the hind limb. And you're right, there's less weight because the head and neck and so forth on the front takes a little bit more of the weight. But again, it's not just about weight. It's like a tibial fracture, which is the bone between the hock and the stifle. Those are really bad fractures, and as they're bad for the radius too often, especially if they're displaced and they're open and they're unstable and they're likely going to get infected. Those are really challenging fractures, and a lot of those horses don't survive. But yeah, that's a good point. And some fractures, yeah, it's nice to have them on the hind limb. Yeah, good question. Yes.
In the example you showed with the proud flesh, where that piece was sliced off, what keeps more proud flesh from developing again and again? And just having
so basically it's continual monitoring and treatment of the wound with your veterinarian. We're often placing bandages on it and continually, and to be honest with you, a wound like that is going to have multiple sharp transections of granulation tissue. Each time it's going to be a little bit smaller, until finally it's small enough that the epithelial cells finally cross. In some cases, we may do something special like a skin graft, where we've had so much, it's been long enough that we just don't have the ability to heal as well. So we're going to bring in some additional skin to help with that wound. But you're right, it's not just one time, cut it away and you're gone. I mean, it can be in some cases, but oftentimes it's multiple transections of that tissue until the wound heals.
Is that just cosmetic, having proud flesh there, or is that actually like a problem? Like if it's completely, it gives a big amount of ugliness.
Yeah, so what tends to happen in the horse is, if it's going to be, if the proud flesh is there and it's prominent, it's going to get repeatedly traumatized. And the reaction of that tissue is to get more and more thickened and exuberant or large. Continues to grow, and also the more it continues to grow, the more likely it is to be traumatized. And then what you see, I don't know if you remember that picture, it was this kind of black mass that was coming off. Well, the reason it was black is because it's all crusted and bloody and continually being traumatized by the horse. And it's going to get worse and bigger until I have seen cases where the proud flesh looks like a basketball hanging off the horse. So they get really bad. And if you don't do anything about it, they often will tend to create problems with movement of the limb and lameness and whatnot. So it's not, I mean, a little bit of proud flesh is not a big deal, and they can go a long time with it. What happens in a lot of cases is that the proud flesh, it'll just become a non-healing scar, and that's the best thing that can happen, where it scars down. You just have a big scar, and no skin, or sorry, no hair, but a big scar, but you don't get this really exuberant granulation tissue mass that forms, and because that's where you need to transect that. If you just get a scar, well, yeah, you have a big scar and it looks unsightly, but the horse might be able to do fine. And so there is a transition there where some horses, if you left the proud flesh, it may just scar in, and you get a big piece of white tissue, white skin that there's no hair, and it's just scar tissue basically. And those horses may do fine. If it's a show horse or something else where you don't want the scar, then yes, you're going to have to treat that differently. But in some cases, in a lot of cases, when it's exuberant or really large, it won't scar in, and it'll get bigger and bigger and traumatic and ulcerated and bleeding, and it's a mess. And so yeah, it has to be treated if you want it resolved. Yeah. All right, hey, thanks so much, guys. I really appreciate your attention.
Thank you.